Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Dr. Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new TEAM therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. His latest book, Feeling Great, contains powerful new techniques that make rapid recovery possible for many people struggling with depression and anxiety. Dr. Burns is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine.
Hello,
David. And welcome, everyone, from wherever in the world you're listening to episode 285. Today we have a really special guest, as all our guests are really special. We have Derek Reilly with us from the UK. And Derek, I'm going to introduce you before you get a chance to say hello. Derek is a cognitive behavioral psychotherapist and a registered mental health nurse with 20 years of clinical practice experience. Predominantly, Derek specialized in the treatment of chronic pain he's worked as a part of a multidisciplinary team providing that practice. He's an accredited CBT therapist with the British Association for Behavioral and Cognitive Psychotherapies in the United Kingdom. He's also certified as a level 3 TEAM-CBT therapist. He's been studying team therapy since 2015, both in London, and he came to the United States to do a 4-day intensive with David in 2017. And he has a particular interest in how team can be used to enhance clinical practice and improve clinical outcomes. Derek is a pivotal member of the TEAM-CBT United Kingdom group, which is working toward promoting and developing TEAM-CBT in the United Kingdom. And I feel so proud that I got a chance to meet Derek when I went to visit the United Kingdom last fall before COVID. Well, that wasn't last fall, but the fall before COVID hit. And Derek's published articles on the treatment of CBT for people suffering from obsessive compulsive disorder and panic attacks. And he's currently in the process of publishing results from a clinical audit where he worked with 60 patients in the use of TEAM-CBT in the treatment of their chronic pain. And it's the first study like this or a clinical audit of its kind in the United Kingdom showing TEAM's effectiveness in the treatment of chronic pain, which all sounds super cool. And just a personal note is that Derek lives in Darfield, which is a small village near Barnsley in South Yorkshire. I hope I'm saying all that correctly, in the United Kingdom. So welcome, Derek.
Oh, thank you, Rhonda. Yeah, that's very accurate. Thank you. Yeah, and Darfield is where I live. At the moment, I'm down in Surrey, but yeah, Darfield is in South Yorkshire, which is kind of a mining area. So yeah, I've lived up there a long time. I'm proud to say I live in Darfield.
Cool. So I'm going to just start off by reading 2 brief endorsements. Both of them are about our special edition podcast regarding the Feeling Good app. I don't know, is it the Feeling Good app or the Feeling Great app?
Feeling Good app. We decided to tone it down a little bit, like a little over the top. I think especially for British, but I think worldwide we decided to take a more modest thing. And Feeling Good is a very well-known brand anyway. So
yeah, it's good to feel good. So Vivek, who was one of the beloved members of the Sunday Hike before they were canceled due to COVID. And he's also an engineer and very interested in team and how it works. He wrote you and said, the Feeling Good app, part 1 of 2, the unexpected results of the latest beta test, which was published on February 28 of 2022. He wrote, David and Jeremy, this is so amazing and has the potential to change the world. I'm sure millions across the globe will benefit from this app. I can't wait for its launch. Thank you.
great. That's so beautiful. And who did you say wrote that one?
That was from Vivek.
Oh, from Vivek. Oh, yeah. He's a fantastic guy. He's from the business world, but he went on dozens at least of our Sunday hikes. I just love the guy, and he's very, very versed in TEAM and just a great joy. And I hope we can get back one day to the Sunday hikes. It's been rough because of COVID and other factors as well. But that was one of the great sources of joy in my life, and I hope we get a chance to do it again one day.
Me too.
Yeah.
And then we have a beloved member of the Wednesday training group is in Pakistan, and his name is Rizwan, and he wrote you also about the same podcast on the latest beta test. He wrote, "Reading your books changed my life completely. I am so much happier and optimistic about life compared to highly critical of myself and others, and had been so much bitter before I read your books. I'm sure your team therapy app will be just as mind-boggling and revolutionary as your bibliotherapy. I'm no God, but had I been one, I definitely would have chosen you as my prophet to spread the message, these messages. Warmly, Rizwan."
Oh, thank you so much, Rizwan. What a kind and generous comment from both Rizwan and Vivek. We sure appreciate the beautiful feedback we get from so many people who are listening to the app, and we also appreciate your support. And for some reason, since we started asking you folks, to tell people about the app, our numbers have been increasing. And we've just had, we're recording this on March 1st, and January and February of this year have been our biggest months ever. And so keep letting people know if you enjoy the app and you know someone who's depressed or anxious, or a therapist who wants to learn new tools, or just a person who needs a little emotional tune-up, to turn them on to the app. Because it really helps us, but it also helps many people, therapists and general public alike, who tell us how much they've been helped by the Feeling Good podcast and by Rhonda's beautiful, brilliant self. And so
David's incredible contributions to the world of psychotherapy and just the world in general.
Yeah. But I mean, we get lots of praise. Occasionally, we get people who kind of try to slam us a little bit too, and sometimes they've got just great criticisms. And every now and then, there's just something with this kind of a mean-spirited. Somebody looks like they're trying to hurt someone, and it's problematic when that occurs. It's rare, but it does capture our attention.
Mm-hmm. Well, let's dive in with Derek. Derek, we were saying that we could talk about three different topics with you.
Can I just say, David, I wanted to echo what those things. I feel super, super proud and really grateful to have this chance to speak to you, because from my personal point of view, I have to say, on my journey in TEAM-CBT the last 7 years, your work and your contributions to psychotherapy have been huge, and they've had a huge, significant effect on my practice, which I think has helped me become a better clinician. And I think with patients particularly, I've noticed that, and that's why I'm so excited to kind of talk about these results, is the change that patients were noting and the rapid recovery. And I think it's wonderful what you've done with the podcast. It's great to hear that they're growing, because I recommend it to all my clients and clinicians. And I know many people find that a wonderful way of sustaining therapy, almost like as part of relapse prevention, and it kind of gives them a mood boost. So it's all wonderful, and you do this all out of the kindness of your heart for free, which I think is magnificent.
Well, thanks so much. And we are thrilled to have you on the podcast today. We want to hear all about your work, the whole issue of working with people with chronic pain. As I mentioned before we started, it's one of my favorite topics. It has been ever since I was a medical student, probably one of the worst medical students Stanford ever had. And I never should have gone to medical school. But the one thing that I really loved, maybe the only thing, was working with Dr. Alan Barber, who was the head of outpatient medicine at Stanford. And he had all the thick chart patients. These were the chronic pain patients that no one could diagnose or help. That's all he did. And that's and I just loved working with him in that clinic, and that's how I got started in that area that you're going to tell us all about in today's podcast.
Yeah, I kind of worked in chronic pain, as Rhonda was saying, for about 19 years in a specialized center, a regional center, which was an NDT approach. But I was always fascinated by chronic pain. But I guess, the whole team model the team framework seemed to fit so perfectly. And it's just been a journey of learning. And I first found out about TEAM-CBT from my actual late mentor, who sadly died, Chris Affer, about a year ago. I remember having discussions with him in supervision and about I'm kind of getting a bit stuck in chronic pain. The models and the treatment approaches are kind of quite limited. The ACT approach has grown more, but in terms of behavioral approaches, it seemed to dominate. And we had discussions, and he said, well, David Burns is great at being an empiricist. He kind of was always looking at what works and changing. So I got really curious then, and then I found out that you were doing a 2-day workshop in Wandsworth, which incidentally, I think Peter Spurrier, who you know very well, who's kind of our lead of the Team UK group, also attended. We didn't know each other at that point, but it was a great 2 days, and it really got me curious, thinking about some of the concepts like resistance and positive reframing. What's good in this? I remember coming away thinking, there's something in this. I don't fully understand it, but it kind of really did give me that seed of doubt, which made me think. And because I think, like a lot of your work has shown, David, that there are areas for improvement, and certainly chronic pain that seemed to stand out a lot. There seemed to be a lot of resistance, and kind of what role was I playing in that, and what role or what could I learn about that could make me more effective and get better outcomes. So that's how my journey started, really, back in 2000, late 2015.
Tell us more. Tell us, we're all ears.
The other thing, just to mention very quickly about the Wandsworth thing, I think at the time, Dave, if I remember rightly, you were saying you were slightly disappointed that.
Yeah, I thought I really blew it terribly. I was so humiliated there, and I probably saw it more negatively than it might have been, because I was so shocked and thrilled that Peter Spurrier had come to that workshop and it had influenced him positively. Now I just discovered you too were at the workshop and it influenced you. So I'll retract some of that. But
it's huge. And also, David, we've found out recently another lady called Francesca who went to that workshop has appeared in the Team UK group. So, there was profound small seeds were planted and they've grown. And, certainly, without going to that, I don't think I would have really known about TEAM-CBT, because I was under the impression that I was the only one in the UK practicing or attempting to practice TEAM-CBT up until 2020, when I discovered Peter's journal article in the BCP magazine, and I wrote, wow, somebody else is using this approach. So I kind of emailed him, and that's how we got in contact, and that's how, as we said later on, the Team UK started to grow from that kind of moment, that chance meeting through a magazine.
Yeah, we loved having him on the podcast. I love that guy. He's so gentle and so deep and so giving and such a brilliant and kindly person. And then Sterling Morey from England has been on the podcast. We're featuring these fantastic, humble, brilliant Brits. And now we're excited to learn all about your work. I just have so much respect for the British approach, because I think it's less commercial, less dollar driven, more focused in a scientific and a humanitarian direction. Just kind of a different spirit that really appeals to me a lot.
Well, thank you. And certainly, I came away then and started thinking. So, I've mapped out some of the real key points in my learning, I think, for team, and also how this really, I think, could help a lot of therapists in terms of who may be involved in team already, may know a lot of this, but other people may not. I think there's really some significant things here for the chronic pain population and how I'm working with that population, which, as you said, can be very difficult and challenging, kind of with the complexity that presents.
Okay, well, Derek, tell us about your work with patients who are suffering from chronic pain and how you use TEAM to help them overcome that.
Yeah, well, I'll tell you, it's a little bit about the journey. When I came back from 2000, I started then thinking, what's all this resistance? And David would talk about the 8 types of resistance and things, what's outcome resistance and process. And I used to go away and kind of start to list what could be the outcome resistance. And it really did get me thinking about how that would look like in chronic pain. And I guess in terms of the chronic pain literature, I said there's been a lot of work, and there has been a lot of work talked about kind of acceptance in the chronic pain literature with ACT and that, and sort of, but they tend to look at it from their theoretical point of view, which is kind of one where kind of you look at acceptance as a kind of general concept where you don't actually look at the thoughts and feelings behind it specifically with the intent of changing them, as I understand. So I kind of realized that a lot of the suffering that pain patients had, maybe I wasn't listening to very well, because in the olden days, perhaps you would see a pain patient, you would assess them, you would try and do empathy and try and understand them. But then kind of what's that one big error that we all make, the biggest therapeutic error David talks about, I think, trying to help people. And I think there was always that little bit that, you'd try and kind of realize that maybe this isn't going away, but let's try and work on dealing with it as if it's not going away. And you'd kind of in the olden days, you would start off with the behavioral approach, looking at behavior and concepts like pacing and educating about chronic pain. But a lot of people used to come up, there was a lot of resistance, I think, at that stage, frustration. You would try and teach people to pace. And for example, I always remember this, and people would say, yeah, but I'm still in pain. It's not really making a difference. And often then on reflection, you were just hoping the resistance would go away. But it kept coming back. And I think, as David well knows, dropout rates are extremely high across all areas, but I think in chronic pain, they can be extremely high. And I'm sure kind of that was a factor. And I know from my own feelings how frustrated sometimes I would get, with a lack of progress. So kind of then when I started to learn about TEAM, I thought, well, yeah, maybe David's right here. We don't do enough testing. In terms of the measures, measuring chronic pain is quite difficult, and measuring psychological measures of outcome. There are various measures, but I think a lot of them have been developed for different concepts, and some may be clinically relevant, some more so. So it got me thinking about the testing and where could that be improved? And I think over the years, I kind of sort of realized that having worked of the typical thoughts patterns that people have, the emotions that keep coming up over and over again. So I sort of came back from Wandsworth, and it was between the period of Wandsworth and going to the San Fran in 2017, I kind of developed my own sort of survey called a pain problem survey, which was kind of a list of whole gamut of emotions, just names of emotions. There were about 16, I think, on it. Whole list of what I thought were quite common repetitive negative thoughts associated with guilt, frustration, anxiety, a whole range of emotions. And also a list of the behaviours or the changes in behaviour that we'd note that were kind of key, and also the physical changes. So I thought, well, perhaps let's gather some data on what does acceptance look like? What is all this suffering that we're hearing about? Rather than trying to overlook it and hope it goes away, let's look at it head on and find out what it really represents. So I kind of started doing that, and I would ask patients, can you just fill this in at the beginning and just rate how much do these problems bother you? And I'd ask them to rate that on a scale of 0 to 10, particularly prioritizing the three areas, like the three emotions that bother you the most right now as you're coming to the first appointment, and the same 3 cognitions, 3 behaviors. So it kind of gave me a lot of data. And from this, I kind of realized, that kind of maybe this was the clues to what some of the resistance was in terms of, as David, the emotional disturbances that people present, that sometimes, as a clinician, I hoped sometimes I didn't deal with always effectively, and I hoped it would go away. So it kind of gave me some ideas about that. So I thought that testing was really key to helping me get clarity. Paradoxically or incidentally, I often found, and my colleagues reported this because I gave it to a couple of colleagues, that when they did this survey, a couple of the physio colleagues would come back to me and say, wow, this patient's ticked this and said it felt like this form was written for me. And they were kind of really encouraged by that. Someone had took some had some understanding of their suffering. So I thought, maybe this is even helping a little bit with empathy and kind of stuff. And then I could use that as dangling the carrot later on. So that's kind of how it started. So it was about getting the testing a bit more accurate. I must admit, when I came back in 2017 from America, I wasn't using the brief mood survey as David had it then. I kind of didn't have the license for that, but I kind of thought, definitely, I need to hold myself more accountable. Let's test what's really going on, what's really bothering patients. So I think that kind of really focused me on kind of that testing bit. So yeah, I feel that was
you found out the brief mood survey at a workshop in the U.S. or the one I did in England.
I think it was the one I got. It would have been in 2017, Dave, when I came to the 4-day intensive. I think.
Oh yeah, right at the South San Francisco. Yeah, right.
Yeah, and testing. So that gave a whole wealth of data, and I think it made my practice more specific and kind of looked at, here's all the suffering. And from that, I was able to gather more and more data of what is this suffering. And because, there always seemed to be a very big difference between a patient would tell you, I remember quite a lot of patients at times, if you weren't very good at empathy and you say, well, what's this CBT about? Well, it's learning to manage your pain or accept it. Patients would say, well, I have accepted it, and get really annoyed because sort of we weren't listening to them. They had accepted it, but kind of there's a big difference between intellectual acceptance versus emotional acceptance. And it was all this emotional stuff underneath that kind of that sometimes we weren't always addressing at the beginning. And I thought, and that's kind of the beauty of the team model. What if we actually head off the resistance at the beginning and worked on this? What difference would that make? So I think that kind of led into that journey. And for me, empathy was huge, but I think the assessments of resistance has been even greater in terms of the impact, the rapid change that can occur for chronic pain patients in terms of honouring and showing what they're suffering, what's really valuable and important about them.
Let me slow you down here a little bit, because everything you're saying is so interesting. And I like to bring things down to the 4th grade level, because that's kind of the level I'm at most of the time. And what would be an example of the resistance, the acceptance, how that relates to depression, anxiety, anger, physical pain. Can you put a face on it? Give kind of an example of what you're talking about.
Yeah, sort of you do an assessment, and like from the brief mood survey, perhaps a lot of the common ones, emotions, was frustration. That was coming through really, really high. And on the survey, kind of, I did have a couple of sort of, you could almost say, cognitive specific thoughts, cognitive specificity in terms of I should be able to do this quicker. I shouldn't be like this. Why me? The doctor should fix me. So there were a lot of self-directed shoulds and outer-directed shoulds that were kind of seem to be correlated with that.
Okay, I'm writing these down, so let me ask you to repeat them. The one I got so far: I should be responding faster. I shouldn't have this problem.
Yeah, why me? Why haven't the doctor should fix me? Sort of things like that.
Mm-hmm. The doctor should fix me. These are good. Some shoulds.
Did you mean to say this shouldn't be happening to me?
Yeah, why me? It shouldn't be happening to me. The difficulty accepting that there's no medical solution to the sort of problem, which is often how people are presented at the very beginning. Really annoyed, angry, demoralized, really upset.
Mm-hmm.
And again, and often what came up as well was there was a lot of guilt as well, more so than perhaps I realized at the beginning, that often that was in their top 3 often of distressing emotions when they asked them, what problems is your pain causing emotionally? And the guilt was around blame, letting people down. I'm putting on people. kind of that loss of identity and, violating their own value system.
How would they be violating their own value systems? Who would they be letting down?
Yeah, in terms of their expectations, David, of perhaps their family in the house, maybe they can't clean the house like they used to do, or they can't pick children up, grandchildren up as much, or can't work as much. I guess work is a huge one. They can't contribute to as much income, so they would feel sort of guilty if they're highly driven people. And
yeah. Now, with the lack of acceptance that you're referring to here, because I think I love what you said, that it's some kind of vague notion of acceptance, but people aren't really saying exactly what we're talking about. And so certainly if people are feeling guilty because they can't clean the house and can't work as I was before, I can't contribute, I can't pick up my grandchildren, then they might not want that guilt to disappear. They may
exactly. Yeah, absolutely. And so, and I guess it was, it's back to empathy. I think a lot of patients we see in the type of service I used to work in, you'd have people presenting with 10, 20 years of suffering, multiple failed treatments. Some of them was failed surgery. You've heard Dr. Hanson talk about how poor the outcome is for surgery, for most medical interventions with chronic conditions. And they're so demoralized. They've often had so many conflicting ideas and confusion, and their perception is they haven't been listened to. So there's really a lot of demoralization and a lot of frustration, tons of it. And the empathy bit, I think, from the model was really important for me, David, because I kind of realized I thought I was reasonably good, but I wasn't that really good. And kind of using your 5 secrets and empathy practice, I think that really helped me, even though I was having to do it on my own, just experimenting. Like the patient will tell me I should be doing more, and then just, practicing. So I imagine you must be feeling really frustrated. Is that right? And kind of things like that, I started to pick up much more. And I think patients really did feel that, and giving them much more space for the empathy. Sometimes I kind of was always too quick to try and help people move into behavioral change, whereas actually really getting this all on the table, really hearing it and honouring their suffering was crucial. And at that stage I was doing the ratings, the rating of the empathy. I'd do a summary after the first assessment, where say you're telling me you're feeling so much guilt, frustration, you've got this anxiety, you've got this and that. I would ask them, can you give me a letter grade A, B and C, highly accurate or very poor? And people would kind of, give me that rating. And I think that helped me to confirm, even though I wasn't using the brief mood survey, that I was getting somewhere roughly right with the empathy. And so that was crucial. Yeah,
I'm proud of you for doing that. It's kind of hard to do that.
Yeah.
And you're always hoping for an A, and you might get an A- or a B or a B+ or a C+ or something. That's awful. If a B- or C+ is just terrible. And then you say, what am I missing? Can you tell me?
Yeah.
Mm-hmm. Yeah.
And as you would say often, that's great. That say, is there anything that would make it A+ that we haven't talked about? Is there something else that you really want to tell me about that's bothering you that we haven't had a chance to talk about? And so, that was crucial, I think, because a lot of them haven't felt listened to. Many patients haven't had the opportunity, because consultations with some specialists are very short, and we're lucky that we have the hour, but it's very brief in time. So,
I'm imagining too that, can I just jump? I'm imagining too that they've had a lot of experience with failed medications.
Oh, yeah.
And doctors throwing medications at them. I sort of had an experience of that recently.
All right.
Yeah, I mean, I went to the doctor because I was feeling anxious about something, and I had a pretty high anxiety level. Within 2 minutes, he said, "Would you like a benzo?" I thought,
right.
Oh my gosh, are you kidding me?
Yeah, I'll give you some benzos if you'll get out of my office now.
Yeah.
We saw much the same thing again when I was just a medical student in Dr. Alan Barber's clinic at Stanford, and he was kind of a mentor of mine who also died sadly a number of years ago. just after his book, Caring for Patients, was published. And it's a wonderful book. It's on treatment of chronic pain patients in medical settings, and patients who and dizziness and fatigue and things that don't have medical explanations. And all of his patients were like that. And one of the things that is the same as what you're saying was that no one had listened. The doctors were trying to prescribe something or order a new lab test, a new x-ray, a new whatever, to find out why this person was struggling with dizziness for so many years, or severe stomach pain for so many years. And his idea was just a very humble one, but it helped about half of the patients that came to that Stanford clinic. This was in the old days. This was years ago when I was still a medical student. But they got over their pain, because he would say, what happened when your dizziness first came on? And, you know, what happened when you began to get this pain for the first time? Or are there some problems going on in your life right now? And he would try to get them talk about their lives and what was upsetting them, rather than ruminating about symptoms in order to get more lab tests. And often it would turn out that there was a troubled marriage, and the stomach pain was, my pain is only when I'm around my husband, type of thing. Gosh, doc, I've been dizzy ever since my wife died. It came on at the funeral years ago, and then it turned out, the fellow had never grieved his wife's death. He thought he wasn't supposed to cry, and he'd been holding in all these tears for years. And what he would say is, I'm dizzy. That's how he experienced it. Once he started to cry, and Dr. Barber just said, I think it's time for you to cry. Yes, it's appropriate to grieve and cry when your wife dies. Then he started sobbing, and he cried for quite a while. And then he finally said, gosh, my dizziness is gone now, or it could have been the physical pain, chest pain, abdominal pain, related to marital problems, believe it or not. And so I just love what you're saying. I had a chance to do some research as well. I want to hear about your research, but I got access to 3 large databases on pain, physical pain, measured with various scales, but it can be measured so accurately and so quickly. I have a 2-item pain scale that has a 99% reliability, and you can fill it out and complete it in 15 seconds. But, where you have pain over time and then emotions over time, like depression, anxiety, and anger were the 3 big ones on my brief mood survey. And then they're correlated. Pain is correlated with emotional disturbance. That's easy to document. But then why is it? Is it because pain causes, say, depression and anger? Or is it because pain and anxiety and anger cause pain, or an amplification of pain? Or maybe there's some third variable causing both. And in all of these databases, one was an arthritis database with 1,000 patients from UC San Francisco, chronic arthritis patients. So these were patients who had real physical disorder causing their pain. And then I had other databases, like at the Stanford Inpatient Psychiatric Unit, where I measured the beginning and end of the pain at the beginning and end of the cognitive therapy groups, and the emotions at the beginning and end. But in all of these 3 databases, I got exactly the same result, that the reason that pain is correlated with depression and anxiety and anger and negative feelings is not because pain causes those negative feelings. That was not the explanation. It was because those negative feelings have a large causal effect on pain, and that can either be amplifying pain that's really there, or actually creating pain when there's no physical explanation for it. But in all the databases, a half of the pain could be accounted for by emotional upset. And what was really exciting was, like, say, in the Stanford inpatient groups, we often were able to cause the patient's negative emotions to disappear completely in a single hour-and-a-half group therapy session, cognitive therapy groups therapy session. And that caused, on average, a 50% reduction in pain. And that's an average. And that meant that some patients, because we had physical pain patients at the Stanford Hospital in the psychiatric inpatient unit. And many of the patients, the pain disappeared entirely in an hour and a half. And they, like yours, they'd been getting failed therapy for 10, 20 years for chronic pain. Others had no effect to change their emotions, and some it went down about halfway. But on average, there was a 50% reduction in pain when their emotions improved. And I've experienced that personally myself when my jaw was broken. And I went to the Stanford emergency room, and I had to have emergency surgery on my jaw. But I was angry and I was pissed off, and I was in excruciating pain. But it was real. I mean, I had been in a bar drinking beer with friends. A fight broke out, and somebody threw this mug, and it hit me in the chin, and it exploded on my chin, and blood came pouring out of my mouth, and my teeth were all loose, and my jaw was broken. But when they finally got the surgeon in, and he put his hand on my shoulder and he said, now, David, I know you're in a lot of pain. We're going to hospitalize you. I'm going to do surgery in the morning. We're going to wire your jaw shut. And then I said, well, am I going to lose my teeth? And he said, you have a lot of loose teeth there, but I don't think you're going to lose any of them. We'll send you to an orthopedic or orthodontist, after you get your jaws healed up. But he said, I've ordered powerful injections of painkillers for you, and you can have as many as you want tonight. Just if you're in pain, just ask for another shot, because everything's going to be okay. And when he said everything's going to be okay, my pain instantly disappeared. It went to zero.
Wow.
It was just amazing. And I never asked for any of the shots until after the surgery. I asked for them then just because I thought it'd be fun to see what opiates were like. But it wasn't for pain, but it made me so aware. My gosh, just the elimination of my fear and my anger. And I felt somebody's going to care for me and take care of me. And then just the pain disappeared. It was just like magic.
Yeah, I think you're right. That a huge amount of the emotional pain is kind of around the issues, and kind of we always just have this idea between tissues and issues, and it's never really about the tissues. People, it's about the issues in their life and the distress, and so much of that does amplify and magnify the pain experience, as you were saying, and once you deal with the emotions, the distress, the pain often calms down, and they show the pain. Although I didn't systematically measure pain reduction intensities, which is perhaps something to do in the future. But yeah, certainly it would have for some people. I know some of my colleagues particularly reported that pain intensity reduced quite a lot as well.
Derek, you said you did a clinical audit with 60 patients. Can you tell us a little bit about that? And without giving anything away about them in particular, maybe you could tell us what some of the people you worked with experienced.
Yeah, so in terms of the testing, I guess I use this brief pain survey, which is kind of something I created to really just look at what is the distress like. But that's not like a validated questionnaire, that's developmental. But I also used the PHQ-9 GAD-7. I don't know if you're familiar with them.
Yes, it's one of the worst tests ever developed, but it is used a lot in research, and it's free. So it has those two redeeming features, but it's not terrible, just not a very good test. I think 7 of the 9 items or something are on symptoms that are not associated in any unique way with depression, like difficulties concentrating or difficulty sleeping, overeating, undereating. Just it's poorly worded. It's how many days in the last 2 weeks. It's just a piece of psychometric crap. But it does give you a halfway decent measure of depression and changes in depression.
You're right. There's a lot of things that can be improved with it, David. And I guess in the UK, I use that because within our services, in terms of, I guess my thinking there was, well, if we want this TEAM-CBT to have a bit of credibility in its results, let's use one of the measures that they're all using. Let's see what it shows on this. So it wasn't specifically for any reasons. And I think you said like things like being slowed down. Well, every pain patient would put yes, and they put almost, and that's listed as sort of a depression symptom as well. So I did that, and I got that pre and post, and that was interesting just to get an extent of what was the prevalence of, clinical depression, the prevalence of clinical anxiety problems. So we did pre and post with that. And, they would that produced very significant changes. So in terms of, it was a sample of 60, as I was saying, Ron. So it's kind of not a full parametric sample, but we kind of gathered data on that. And I had some help from a statistician where I used to work. He was very helpful, Jim Chapman, and he did a Wilson-Cox sign rank test. And that showed that the results were very significant. The p-value was 0.00001 in terms of its significance. So to give you an example, the average score, I think, for the GAD for the PHQ-9 was about 16.6. So everybody would have had an average score of, I think that's about severe depression on that scale. By the end of treatment, I think the average was down to about 7.2, which is, around just into the normal range of what's considered normal. So they would have nearly everybody fully recovered. And in terms of a lot of services, they won't take anybody on unless they've got a score of 10 or above. So most of them would have been fully recovered. So it was making dramatic changes. But some of these changed, and the same with the GAD-7. I think that went from an average of 16.4 down to about 7.2. So people were recovering very quickly. And this was really, really interesting. But also on the pain, the brief pain problem survey, that people's levels of frustration and guilt were going right down. All of the distress was going down using the team approach, particularly kind of the assessment of resistance, and then melting that away, and then tidying it up and with the different appropriate measures, methods. So that was really quite significant, and that's hopefully what we're going to try and report in the results. I've actually co-writing that with my friend and esteemed colleague Anne Garland. She's a consultant in CBT psychotherapy works in Oxford now at the Oxford Cognitive Therapy Centre, which is probably one of the organisations who would mostly appreciate and understand your work, David, in England, I think.
That's really neat. So the PHQ scores went from 16.6. What's that, goes 0 to 27 or something like that?
That's correct. That one's up to 27 because it's 9 item 3.
And then went from 16.6 to 7.2, and that was statistically significant at the 0.0001, less than P is level.
40, yeah.
And then what happened? And then what happened to the pain? You said that you were measuring pain, or you weren't measuring pain, or?
I was measuring the pain-related distress specifically. What were the things? Because when I actually asked them and did the review of that, the key 3 emotions, frustration was number 1. I think 70% of them, that was in their top 3 of the emotions that most bothered them at intake. When I looked at it all, then there was guilt was up there. It was surprising, and then it was anxiety and depression. I think sometimes perhaps I did wonder about with anger. I think some people didn't always like ticking the anger much. Maybe frustration was more kind of a socially acceptable way of talking about it. But I think a lot of anger embedded in there as well. And I often think they're a bit like brothers, those two, frustration and anger a little bit. But
Derek, you mentioned the generalized anxiety disorder score also went down.
Yeah, that was from 16 point something to 7 as well. Very significant change. And again, when I actually looked at the number of sessions, they were like, out of that 60, I think 25 people got better within less than 5 sessions. So that's including the first session would be a full assessment. So, to me, and I don't have the specific data of what I used to do in the previous years, but this was far more rapid change, which again, confirming David's work that the TEAM-CBT model, but by addressing the resistance, I do think the game changer is the resistance. I kind of, when I used to just love melting this away, let's look at all the frustration and the guilt, what it shows that's good about you. And people would kind of really kind of go away, and you are really kind of making them feel so much proud and appreciate their suffering. And I think that makes a huge difference. And it is a deeper form of empathy. I remember thinking about it recently that, when you're doing this with people, I think it really is showing how much you understand them and what's really good about them. And I think once you start to bring that to light, people, and I often think it almost feels like uncovering, when I've done it with patients, we're uncovering what's really good and value about them. And I think that resonates for a lot of people. I've got about 30, 40 written testimonials of people. Can I just read one out very quickly?
Yeah, absolutely. I love what you're saying, by the way.
And bear in mind that I guess the area that we cover, South Yorkshire, is quite an economically deprived area. It's heavily working class manual. So there's been a lot of economic deprivation for years, unfortunately. And some of the patients, I'm just thinking of this person in particular. I know we might have thought, well, this chap would never be able to do cognitive therapy. He can't access cognitions. Those assumptions people would make. I think some people might have considered this, but this was his testimonial after doing some brief work around. He had a lot of anger and frustration, and we did assessment of resistance. We did a lot of semantic work, just challenging those shoulds. And this is, I guess this might highlight some of the British approach as well. This was his testimonial. I was very uncertain of this procedure and thought it was going to be a load of codswallop. I don't know if you
thought it would be what?
A load of codswallop.
Codswallop.
Okay. That's English, really. British for a load of rubbish. It's a waste of time.
Oh, yeah.
But so he said that. But upon my third visit to Derek, I can see the change in myself, the way I look at things differently. I do things the way I do. I think about doing things. I cannot believe the results I am seeing and doing brilliantly. As I said, I was very skeptical about this and would recommend this procedure to anyone. Absolutely brilliant. So with him, that was doing full-on assessment of resistance. And then really what I found, David, and this is the back to front, that when you address the resistance, totally confirming your ideas, that you look at what's good about his frustration and his anger, and then we just tidy that up into appropriateness in terms of, let's take the shoulds out of your frustration and move to a more of acceptance way of being, that then they would sort of pace anyway, and they would just go about their business. You didn't need to teach them how to pace activity, essentially, like what we do. We used to do it back to front, or I used to do it back to front. So I felt, like him, and in 3 sessions, he was telling me he was pacing his activity, and he was more calm and accepting and had more peace.
Well, that's so neat. I love hearing that. And what happens to us, and I bet it happens to you too, is that when your patient starts feeling better, then it affects us in the same way.
Oh, yeah. Very much like you, Dave. I always, I do really, really enjoy it. It's such a wonderful and grateful thing to be able to see rapid recovery before your eyes. And I would see it in the sessions. People would say, this is mine. This is really a game changer. It's changed my mind. And for my eyes, I used to get lots and lots of feedback with the resistance. So I think for chronic pain, I think that's an area that has been overlooked. I think in chronic pain, there has been attempts to do motivational interviewing, but it's all a bit haphazard. It's not systematic, whereas the TEAM model totally addresses that. And that's kind of really, once you melt that as resistance away, I think trying to treat a chronic pain patient is much more kind of easier and more effective.
Yeah. Well, this has been a real eye-opener and just a delight. What do you have? Some questions to Rhonda?
I don't really. Every question that I was thinking of asking you, Derek, you answered. You had mentioned in the beginning that there were some, negative thoughts that most people who had chronic pain shared, and you shared some of those with us, that they were the should statements, and the outcome resistance where you're working on positively framing the challenging feelings that they have. And you talked about that. And, it seems like, the team structure and the model fits in so well with this population, as you've described. The results that their depression scores went down, their anxiety score went down. And then, you gave that lovely endorsement from one of your patients. I wonder, would it be too much to describe a process that somebody went through with you?
Yeah. What sense were you thinking, Rhonda, sort of?
Like kind of describing like this person came with chronic pain after he'd had pain for X number of years, and he was very, resigned and angry and frustrated, and his levels of frustration were 80% or 100%. And then you went through what process you went through, what were some of their negative thoughts? I mean, I don't know if you're prepared to do something that specific. And then how did they reframe their feelings so that they could really, see what's beautiful about them, or see what the advantages or see how their feelings, spoke about their core values. But maybe I'm putting you on the spot. You might not have that specific example.
No, I can think of I kind of think of a more recent case. This would have been in the last 2 years, because I left my post a few months ago. But there was a guy, again, it's anonymous, let's call him JH. I remember he'd been assessed by somebody previously about a year ago, and he'd been on our waiting list. We had a long waiting list. I think he presented with long-standing back pain that had been aggravated through an injury, but also depression. He'd had a suicide attempt about a year previously and was feeling really, really low and useless. And he was actually a former farm worker, and he'd also been drinking a lot excessively, I think up to maybe 12 units a night, to sort of just try and blank out the distress and the pain. And I remember seeing him, and he was really, really struggling. There was a lot of problems there, and kind of like, well, what are we going to do here? And so we kind of looked at, kind of what was his distress, what would he like to work on? And I think a lot of people with chronic pain, there is always that difficulty. At what point do I need to accept this is maybe like a long-term problem where I've got to work on my role in it? A bit like, I guess it's going back to the process resistance. I often thought with chronic pain, it's a little bit like, you could almost say it's our relationship with this pain. It's like the resistance for a relationship, but often are you willing to look at your role at this stage? Some people aren't. So I guess you have to sit open hands. Some people are still very much convinced they need to look for a medical solution and stuff. And I remember years ago, I would try and persuade people not to do that. And I guess you get frustrated. So sometimes I found sitting with open hands there. But for this gentleman in particular, he was willing to look at that. So that was a good sign. And then kind of...
Just to stop for just 1 second. That's what Alan Barber also found. He did informal research at Stanford. He wasn't like a formal researcher, but he said about half the patients were helped greatly by this psychological approach, but that half of them had no interest at all. It's like they wanted to have their symptoms. They wanted to have a medicine. They didn't want to, some of them had to like slam the door shut type of thing. And others were open and eager.
Like you said, with the antimony di mello, they yearn for change, but we cling to the familiar, don't we? And
right.
They've all been socialized into this model that pain's physical. It needs to be reduced by medication or an intervention. So that kind of that resistance step was really, but with this chap, he was kind of ready to start looking at that. So we kind of looked at, well, what are we going to do about your drink? Do we need it? That's one of the requirements. You're going to have to be willing to cut down on that if we're going to work on this. And I remember thinking, how is this guy going to respond? But he started to cut down, and I remember diving straight into once we checked for empathy. He had a lot of guilt, he had a lot of depression and a lot of frustration. And we started doing the positive reframing. What did it show that was good about him? It showed he had high standards. He was a farmer. He was always quite a perfectionist. He was a very determined person. I think a lot of chronic pain patients all score highly for determination. When you look at what's valuable about them and their frustration is that they're often very determined. They've been trying to fight this pain for a long time, trying to work through it or try and overcome it. So they've all got lots of determination. So I think that was really one of the most valuable things that comes up when we do the positive reframing. You know, the standard things with the guilt. He's got a conscience. He feels he's letting his wife down because he's drinking. Also intense shame that he's got to this level that he's not working. So I think that was getting triggered. So we looked at what does that show that's good about him, his conscience, his high standards. He's honest with himself. He's really stuck now. He can't get back into work. That was the other thing. He also did mechanical work, so he couldn't get under cars anymore. So he was really, really beating himself up intensely about that. And the depression that, you know, I've lost me, I'm not me anymore. So it shows he's aware of loss and that he cares about his life so much. So there's a ton of things. And I think for someone like him, when he used to do the positive reframing, I think we generate 40, 50 items on the list. So that can be quite amazing. And I think he was like shocked at that and said, wow, I didn't realize there was all this behind. So I think that in itself has a mood lifting effect. I found that, David. I often used to, when I did the positive reframing, because I was only have an hour session. For example, if we did guilt with someone, when I'd ask them at the end, how's your guilt feeling now? People would say the thing had just reduced, go from maybe it was 10 down to 7. So I was gathering a little bit of testing that positive reframing is reducing it, even though it may, you know, you've got to look at it at the specific level and challenge it. So, you know, it clearly was having this mood enhancing effect. And I think once he did that with this chap, you know, a lot of that was melting away. And then to bring the guilt down, I think they pressed the magic button and he wanted his guilt to be turned down to 2 or 3.
Yeah, right.
One observation I had, David, I don't know if this is relevant or not, but sometimes when I did the positive reframing and we'd really try and milk it, get everything we can out of it that's really valuable, because there is a ton of things, isn't it, when you look?
Oh, yeah. Mm-hmm.
When we did that, and sometimes I would say, okay, here's the magic button. Now, it doesn't make sense to press the magic button, but what about if we had the dial? What level would you prefer to turn it down to that's more healthy so you keep all the benefits, but perhaps it would be better for you or more healthier in the long term? They would often say about 5 or 6. So I kind of felt that if I was doing that quite well, they didn't want to turn it down too much because they were realizing how much good stuff was in it.
Well, you've been more successful than I have, because I try to get them to give high estimates, but they're generally wanting to go from, like, say, an 80 on depression or guilt or shame or whatever, down to a 5 or a 10 or something like that. I don't know. What's your experience with that, Rhonda?
Well, I think we want to remind people that, you know, that you're dialing down so that you can just keep enough of the feeling, whatever it is, frustration or anger, so that you can keep the great parts about themselves that's embedded within that feeling, but let go of the pain and the suffering. So I just feel like it's not for me to judge how much they decide their pain and suffering is overwhelming. And maybe they're perfectly capable of maintaining the great benefits with only 5% of it, because that's how much they're suffering from it, from the depression or the...
Right. I just love to hear you saying this, because it's like unbelievable to me, because I'm always teaching. I'm saying, does anybody get this? Does anybody care about what I'm saying? And people are always busting me and saying, oh, I don't believe what you're saying. And, you know, or they've got to talk about their childhood experiences or something like that. So I'm just so grateful to have you on the show today and show how you're just so beautifully and accurately picked up the vision and you're sharing it with your patients. It's just kind of blowing my mind.
Well, thank you, David, and thank you for your wonderful clinical insights, because I think this is a game changer. And from that stage, then that's just, you know, as you say that word, it almost does feel like you're melting it away. And then the techniques would slot in. And what I found that for a lot of people, and I remember in this case in particular, we would then kind of look at all the shoulds, the hidden shoulds, and often using some of the semantic with lots of acceptance in there, you know, and changing it from I should do, you know, to phrases like it would be nice, particularly, but also it's okay to feel this way at the moment because I'm just, I'm not working. But a lot of people, once they move to that kind of preferential way of thinking, which was self-acceptance more, that made a huge difference. So I found like the semantic technique is one. Once you've melded it away, if you want to tackle, because there is a ton of shoulds in that frustration and guilt, if you tackle them using things like the semantic or the double standard and many other things, but particularly semantic, I found that really interesting that, it's kind of like, and then, it's like that, there's theoretically, it seemed to be everybody's looking to be their old self and here's the current self. And there's that dichotomy or against the idolized self versus current self, like with the Albert Ellis sort of stuff of the demand in things. And once you took some of those demands away and the self-criticism, then people could move more towards acceptance and this pain would calm down and they would be able to adjust and live a sort of more meaningful life with less suffering.
Oh, that's incredible.
So yeah, with him, and one other thing I used to do, David, at the end, I don't know, in terms of relapse prevention, I used to, because I would jot down all the negative thoughts as I go along, I would almost then, as the relapse prevention, do externalization of voice. And I remember with this gentleman that we did do this, where I would then just play the negative, critical old self and read all of these out, and he would have to defeat all of them in the last session. And I remember finding that quite a good way of, so let's see how far have we changed here. Have you got it on the gut level yet? Can you do it right now? So that was always a really good checking point, I think.
Oh, I agree. It's so important to be able to do the externalization of voices and have them blow their thoughts away. It just brings it to a whole deeper level. And of course, there's I've been, as you know, I'm working on the Feeling Good app, and I just did the draft of the relapse prevention training lessons. And here's the 6 thoughts you're going to have when you relapse, in addition to your own unique ones. These are the ones everybody has, and the externalization of voices pushes things to a deeper level than just the positive reframing or the semantic technique. One thing you just said, and we probably got to stop here pretty quick, but that the semantic technique is a way of getting acceptance. I hadn't thought of it like that, but you're absolutely right. I've been also trying to figure out what are the various tools we can use to teach acceptance. And I don't have the complete answer to that yet, but I like what you're saying, that the semantic technique for the shoulds and the hidden shoulds, that is an aspect of acceptance. And maybe people who feel the semantic technique or the double standard isn't strong enough for their shoulds, then those are the people who don't want to give up the, beating up on themselves. They're not ready for acceptance. But I think we need to have a list of the 10 techniques that we can use to help people grasp the acceptance paradox. And I love adding, the shoulds and hidden shoulds and how to get rid of them. That's certainly a big piece of that. And I think all of the positive reframing, that's emotional acceptance.
Oh, hugely. And it's exactly. And it's emotional education as well. Yeah. That people begin to realize, wow, this is a good part of me. I need to keep this and I appreciate this. And so I've always thought it's about, and going back to the semantic, I used to give patients a sort of a sheet with a list of 6 alternatives. So it would be nice, it would be great, it's okay. Yeah. Right. So they could then say, okay, you've got a choice now. You can keep beating yourself up with this should and feeling frustrated. Or perhaps you could soften it and maybe use one of these, and then they could choose. And so I thought that sort of helped.
Oh, yeah.
People.
Yeah. It's exciting, isn't it? To have all these tools.
Oh, absolutely, David. And, that's it's tools, not schools. Absolutely. And, I have a tremendous respect for the work of Ellis. And I used to work with someone who was very much in the REBT camp, but moving away from schools to tools is one of the other great ideas of yours, which is if more people embrace that, I think it would be great for patient outcomes and treatment.
Yeah. But some of the listeners don't know that's the name of my ebook that psychotherapists sometimes use in their training. Tools, not schools of therapy. And you can find it on my website, should you be interested in the shop. I have a question for you, Derek. Are you involved in a weekly training group? Are you like teaching people or attending as a student or doing it as a teacher? Or?
Yes, Rhonda kindly invited me into the Wednesday group last year, so I was involved in that for quite some time. Unfortunately, I had to drop out a little bit due to personal reasons, but I'm also involved with Peter and the UK team group, which is exciting. On a Tuesday, we do training on the Tuesday afternoon, so cool. That happens, and there's meetings, and so yeah, and the situation in the UK is improving, and thanks to the work of Peter. Peter's been so wonderful, and Rhonda knows that from the meeting in the summer, how he really is the figurehead of it and really organises a lot, and he's, it's thanks to Peter that it's grown as much as anyone.
He's a hell of a tremendous person. Yeah. He's just fabulous. For the listeners who don't know, he's a physician in England, and he decided that he didn't want to have those 10-minute only sessions for diabetes and blood pressure and whatever. And he learned about TEAM, I guess, by going to that workshop I did in England, and he's just fantastic, and he's giving birth to the whole TEAM-CBT movement in England. And of course, you, Rhonda, have facilitated that by going there in person and bringing people together and so forth. I'm just so exciting. And then I hope that you'll have some contact with Sterling Morey too. He and I are going to treat somebody on a podcast live that, we won't use it unless the woman is happy with it afterwards. But he was my first student in the United States when I was just learning cognitive therapy, and we sat together for 2 months doing co-therapy together. He's just fantastic. And I'm so excited to have a chance to work with him again now after 40 years. And see if we can recreate the same magic we had when we were both much, much younger. So I'm excited about that.
Yeah, that's going to be really exciting. I'm excited about that too. Can't wait to pull Sterling back into the TEAM community. Derek, if somebody is listening to this podcast in the United Kingdom and they want to be part of the UK Tuesday training group, who should they contact? How do they get in touch with you?
Usually it would be Peter, but there's the Peter Spurrier, which I think his email address. That would be the port of call. There is if people are interested in just finding out more about the Team UK, there's the feelinggooduk.com. I think it is. That's where most of us are listed. So if people are interested, there's that. And
but that's Feeling Good. Is it .uk or just Feeling Good?
Feeling Good with 2 G's. .uk.com, I think it's feelinggooduk.com. So that's kind of got a list of all of us, the people that are involved, and we're always looking.
When they go to that, then they should look up Peter Spurrier. But I think Peter was okay with us giving his email address because he did it the last time he was on our podcast, I believe.
Okay. Yeah,
I'll add that to the show notes. Can you give us your email too, in case some listeners want to contact you about your work on chronic pain and TEAM-CBT?
I'm on the feelinguk.com, but yeah, my email address there. But I can give it to you now if you'd like it.
Sure, that'd be great. Then we'll have all this in the show notes too. For those of you who are listening, you want more info, go to the show notes. But yeah.
Okay, my email address is lowercase letters, D for Delta, W for Water, R for Roger. Then it's
DWR.
Yep, 1971.
1971.
And that's a yahoo.co.uk.
At Yahoo dot what?
.co.uk.
.co.
.uk.
.co.uk. Okay. DWR 1971 at yahoo.co.uk.
That's correct, David.
Cool, Derek. Thank you so much for talking about us. Now you taught us a new word, codswallop.
Yeah, I thought you might like that. And I was very, very touched to listen to the story. So I can't wait to hear that podcast. So yeah, keep it going, David. It's amazing. And I hope you'll come to the I know you said you would come and speak to us on the Tuesday group in the afternoon on the Zoom call. So we're all looking forward to that one day. We'd love to.
Yeah, has it been scheduled yet? I think I offered to do it, and then I don't think anyone picked up on it. I did some Q&A at a CBT conference or something like that, but I'd be happy to come in and if it is like a Q&A session, I love Q&A, and then I don't have to prepare. Yeah, and it can be really fun too.
Yeah, those are really fun.
We'll arrange an ad hoc 1 hour Q&A, Dave. I think the Team UK people would love that, and I certainly think that would be fantastic.
Yeah, or we could do an hour and a half, actually, because once I get into Q&A, the time passes so damn fast. So, yeah. Well, congratulations on what you're doing. I'm just blown away and very excited. What you're doing is real. It's valid. It's helping people quickly. It's a game changer. It's a paradigm changer. And I'm just absolutely thrilled to meet you and thrilled to hear about your work.
Oh, thank you, David. You might have remembered me from I mentioned a very little the end at the conference in 2017. I don't know if you remember, we had to get up and do a little speech, and I kind of got up and I was the guy who got locked out of his room. I don't know if you ever remember that one.
The guy who did what?
Who got locked out of his room in his underpants. Do you remember that story?
Yes.
What was it, Rhonda? I didn't quite catch it.
Well, actually, this might be a funny way to end the podcast. Derek, tell us what happened.
So basically, I got up the mic. I kind of I went to the toilet. It was while I was doing the intensive, and unfortunately, I was at the end corridor. As I came back, the latch had gone in, so I was locked out on the 9th floor in my underpants about 9 o'clock at night in a very busy hotel. And of course, I had to go down the walk of shame downstairs. Of course, there were lots of young, attractive people waiting. And of course, there's me in my underpants. And I had to go and speak to the reception guy. And he seemed to be sort of like slightly blind himself. And he said, "Oh, don't worry, it happens all the time." And he gave me a spare key. And I had to do the walk of shame back up. So, yeah.
Cool. So that was your shame attacking exercise?
Yeah, not intentional, though. That was unintentional.
Yeah, cool.
Okay, well, thank you so much, Derek, for taking the time out of your busy day to speak to us.
Thank you.
And thank you, everyone, for listening.
Okay. Bye-bye.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. I am your host, Rhonda Borowski, the director of the Feeling Great Therapy Center. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.